us for our ECHO Long-Term Services and Support COVID Preparation Series. A special thanks to our collaborators, the Hawaii Emergency Management Agency, the Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. We usually have a brief presentation open up for a time of discussion and questions up till 3 p.m. So we ask you to use the chat box to submit and to queue up your questions. Next slide. This is the schedule for our upcoming sessions. Please note, let's see. Yeah, so that's today's. And then next week, we have protocols and strategies to protect home care providers. And we will be actually having a special guest, Anthony Dawson from the Visiting Nurse Services of New York, who has gone through the pandemic like no one would believe. But they've actually developed lots of good protocols and strategies, and we have a lot to learn from them. We'll be offering CMEs, and nurses can use for CE purposes as well. We will offer certificates of attendance to all participants who complete an evaluation. The evaluations can be found on our website under the Evaluations tab, and we will also have a link in the chat box that you can click onto right after the presentation today. We ask you at this time to enter the names of all the attendees in the chat box. That's yourself, I guess, for attendance purposes. And for those of you calling on the phone, if you can just tell us your name, then we can write that down. So let me just check here in the participant list and see. We actually have a number of people on the telephone. So if anybody wants to unmute yourself and just give us your name, that would be great. Give you a couple seconds. Everybody's shy. Okay. Anyway, so introduction. So today we are covering the entire spectrum of long-term services and supports in Hawaii through this ECHO. And today we are going to hear about MedQuest COVID support for LTSS. And we will be describing how MedQuest is supporting patients in different LTSS settings. That is like places in nursing facilities, for those with developmental disabilities, community care foster family homes, community home and community-based services. And so if you are caring for patients in these settings, we hope you find this session informative. Dr. Curtis Toma is leading this off for us today. He is the Hawaii Medicaid Medical Director and the lead of medical resources at HIEMA. And he has also invited a few other folks to join him in this presentation, who he will introduce. Go ahead, Dr. Toma.
Thank you, Dr. Idawan. So Curtis Toma, and I have a panel of 4 speakers today, so it's going to be pretty quick. And first up is Dr. Leo Pasqua, esteemed pediatrician in Waihoa, good friend and mentor to me for decades. And Leo's going to talk a little bit about his personal experiences with COVID, very inspirational perspective. And then I'll follow after Leo as the first of 3 more panel speakers. Thank you, Leo.
Sure, thank you for the introduction, Curtis. So when Curtis asked me to talk about this, it came on the heels of some other requests that I had to talk about this experience. In brief, what happened is that in March 12th, I left here to go on vacation. I went to, of all places, New Jersey and New York to go attend my daughter's engagement party. And I came back on March 22nd, and on the way back, I felt bad coming back on the plane. And then maybe about 1 week later, 5 days later, I found myself sitting 84% on room air and walking up the stairs to Queens Hospital and into the ICU. And next thing I knew, I was intubated and ventilated. But with regard to, I was trying to think about how this could be helpful instead of me just talking what I've been through. Looking back at it in retrospect was, I think what helped is that before I was intubated, I had an idea as to what that meant. And as clinicians, you know, you've had to make some decisions like that as to when to intubate a patient. So when the intensivist came up to me in full PPE battle gear and said, you know, Dr. P, I think we may need to intubate you. I said, okay, sounds good. Do what you got to do. Because I was already having a hard time breathing. I think I was sat 92% on 11 liters blasting through a Venturi mask. And I said, sure, go ahead. And I think he looked at me like, okay, I think, all right, well, fine. But let's try some other things. Let's try proning. And he explained that to me. Let's try some other measures. But they explained to me everything that was going on. And then they explained to me again, apologetically, that they would have to intubate. And I said, no problem. So it helped that I knew kind of what to expect. So when they busted into my room at 1 o'clock in the morning and said, okay, Dr. P, we got to intubate you. We're at that point. I noticed what they didn't say, because you can still process while this is going on. I noticed he didn't say anything about respiratory failure or pulmonary failure. There were no words like that. There were no failure words or saying bad things. And I said, okay, sounds pretty good. It was all optimistic. We're going to help you breathe. We're going to help you. I said, okay, fine. The next thing I knew is I was kind of going in and out of consciousness, because as the sedation is administered, while they go through the rapid sequence intubation, you kind of go to sleep, and then when you awake, you may have a little bit of consciousness there. I remember looking around, and in retrospect, I was kind of looking at the ceiling. I was feeling no pain, feeling kind of disoriented there. And I would go in and out of these experiences. And I guess the thing that I would be able to say is that even while you are going through these instances, you are still yourself. You do not at any point go, gee, who am I? You still have your identity. And what was interesting is that everything then starts coming at you. You have some superficial thoughts that you think all the time, the ones which are here at the surface, like, what am I going to eat for dinner tonight? And gee, I got to get out of here because I got to get back to work. And then you have all the other things that are there. Those are the things that you sublimate on purpose. Because if you think about these things, then I don't know what you call it, your subconscious or your superego. If you think about these things, you get too anxious, and you're never going to cross the street, and you're never going to try anything. But these things kind of coexist in your head at the same time. And so I think what helped is all of the things that a person ponders about and thinks about can be brought into that situation, even though they're kind of staring down some very, very difficult sort of things. One of the things that helped me through this was before I went into this situation. It was just before Easter. And I'm the choir director for our church, and so I'm supposed to sing a song for Easter. And while I'm kind of going through this experience, part of me remembers, man, you got to get out of here, Pascual, because you're supposed to sing a song in church for Easter. How does that song go again? And I'm trying to sing this song in my head, and I remember one of the lyrics was, da 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 da, be not afraid. And I thought, okay, all right, sounds good. Meanwhile, maybe this feeling of disorientation and fear still comes around, but then that song is still in my head. Da 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 da, be not afraid. Oh yeah, I got to sing that song for Easter. So you're still able to hang on and maybe think of things which give you hope, even in that situation. The other thing too is that I love to read, and the things that I read, I tend to like underline them and really think about them. And one of the books that I read many moons ago was this book. Here's the cover. It's called Harold Bloom Genius. Okay, and what he did is that he took 100 writers, and he tried to figure out what was their genius quality. And number one on the list was Shakespeare, because he tended to overhear himself. He would make up words. And then I kind of went down this list, and I just got back to kind of writing essays on each one of these things. And one of them was this character over here, Giacomo Leopardi. And he was a writer in the 17th and 18th century. And one of the things which underlies these writers is that they remind you that even when things are dark and you are in the void, you can still be your best friend. You can still seek some sort of epiphany that's there. And I remember, again, I tend to be compulsive. So in the book, I started to write little notes in the margin over there. And one of the things that he said Leopardi said that even in the depths, you can seek an epiphany. Even when things are dark and despair, you can seek an epiphany. And I just kind of remembered that. I thought, okay, here I am in this weird place. What possible epiphany can I get out of this? But just the fact that you're still wondering, you're still problem solving. And as clinicians, if you ever find yourself in this situation, and hopefully you don't, but then you never know nowadays because COVID is just kind of right there around the corner. You're still hopefully able to problem solve. And you think your way through this, and you drift your way in and out. And then at some point, if it works out pretty well, you wake up, and yes, you are still delusional because the anesthesia is wearing off, but things follow you from that depth. And one of the things that followed me out of that depth were the words, "Be not afraid." And so I guess that would be what I would share with you is while we're going through this pandemic, is not to be afraid of COVID, but respect it. That's different, okay? COVID is like the ocean without any benefits. You don't turn your back to it, and you respect it. And you put on your gear, and you put on your mask, and you put your PPE, and then you proceed to take care of your patients. As for your geriatric patients, they are a very vulnerable population, and you never know when COVID may catch up with them. And so at this point, you can encourage them to engage in thinking, problem solving, reading their books, discussing their books with them, so that if they should find themselves in that sort of situation where they are in a dire situation, then at least they have their faculties about them, and they can still try and problem solve their way through this.
Thank you very much. Thank
You're
you
welcome.
for sharing your heart and your insights and reminding us that we can actually still talk to our patients even when they're intubated.
Yes, because people will say, "Hey, Leo, you remember some of this stuff?" I go, "Yes, I remember seeing some very weird things in front of me." And at one point, I was fighting the restraints because of this. I felt like I needed to get past the restraint in order to do something. But my arms were tethered down. And I remember hearing a voice on the side saying, "What are you trying to do? Okay? What are you trying to do? Okay, look, you almost kind of fell off the bed over here. Now get on back to the bed. All right?" And the issue is that you can hear and you can inwardly comment, but you can't say anything. Okay? So I think that if I had heard at that point, "Hey, Dr. P, listen, I know you're seeing some weird things in front of you, but this is a voice from outside of all that. You're doing fine. We called your wife, we called your family, we're giving her good news every day. Okay? So just relax. Even though what you're looking at is some weird hallucinatory stuff, you're a smart guy, you can figure all that out. That's probably anesthesia kind of freaking you out a little bit, but we're doing fine and you're making improvements every day. You're setting 1% more than you did yesterday. That's all right." And at one point, even though I'm not even able to respond to that, I would think that the clinician looking at my heart rate would have seen it kind of drop a little bit, because I would be saying, "Yeah, okay, thanks." My daughter, who knows me very, very well, she wanted to call and she wanted to ask maybe they could play some music that I would want to hear, which would have been hip hop and R&B, but then that would have been the soundtrack to all that hallucinatory experience that I had. But I still would have liked it. But yeah, the intubated patient can still hear and they can still comprehend and they can still process what you're saying.
Okay, thank you.
You're
All
welcome.
right. Yeah. So Curtis, you want to continue?
Yeah, I do. Wow, Leo, that was great. It's great to hear a firsthand experience, and it really brings home the reality of COVID. So before I transition is there anything you want to tell the RNs? A lot of RNs on the call, a lot of case managers, social workers that work with the Medicaid at-risk population, geriatric Medicaid patients. Is there any message you want to give to them?
Yeah. It just gets down to be not afraid. Because if there's one thing which accompanies this with pandemic and everything that you hear is fear, right? And maybe some disappointment depending upon what age they are. So you have young people that are disappointed that they can't go to the movies anymore, they can't hang out with their friends, okay? And then you have an older population which is disappointed that they can't go visit their grandchildren. And then maybe you have another population that is just worried inwardly that if they catch COVID, then this is going to be the end of them. And there's that fear that's there. And so it's just letting them know, be not afraid, respect COVID. And what helped me is even when I was going through this uncertainty, I knew that I was supported by smart people because I knew there was an intensivist there, and my infectious disease person was there. And so this is one thing, is when I remember, kind of starting to kind of fall asleep, the only thing you can do is visualize. And I remember times for visualization. And I just thought about all these COVID particles coming at me, and I just remember these little samurai swords coming out of mine and just kind of taking care of it because I was visualizing my immune system. But then at some point, I remember having a conversation with COVID, and I got nasty. I said, okay, look, they intubated me. You're on my turf now because I know what this is all about. To my left, I got my pulmonologist friend and the intensivist over there. And to my right, I've got an infectious disease specialist. And these guys, COVID, are going to take you apart with a blowtorch and a pair of pliers. I don't know what you thought this was all about, but you're on the clinician's turf right now. And you just start to get nasty. And so I think that for the RNs and dealing with the geriatric patients, they can talk to their patients and they can give them this kind of feisty attitude that they can take with them in the event that they find themselves overcome and need some help. They just need to know, we're not giving up. You're surrounded by smart people over here. And feel free to tell them your credentials. Absolutely. Because that's what I went after.
Wow, that's great, Dr. Pascual. I really thank you for that. That was very impactful, very helpful, I think, for the case managers.
You're welcome.
Wow, I feel like my part is not so important, but I'm going to jump to the opposite extreme and go over some data and numbers. Next slide, please. So great first-hand experience by Dr. Pascual. I'm going to go over some numbers with Medicaid, and then Dr. Brian Wu, pediatric pulmonologist, will follow with some clinical aspects, and then we'll close with Dr. Ryan Lee, who's the medical director at the DDD division. Next slide, please. And I'll be going fast on purpose, but these sessions are all recorded. You can always go back later. So nationally, there was a big push to deinstitutionalize the geriatric long-term care, especially for Medicaid. So CMS came up with a mandate to all the states a while back. And back about 8 years ago, it was about 50-50 nationwide in terms of home and community-based services and institution. In Hawaii, it's about 75-25. Next slide, please. So what we do is, the first question is a patient ICF or SNF? Then there's a tool that's called an 1147 level of care tool that they implement. And it's either a yes or a no. If it's a yes, then the patient has a choice between going to a nursing facility or being treated in a community under home and community-based services. Medicaid has 7,500 on the community side and 2,300 in a nursing facility side. Next slide, please. So in a nursing facility, we have 2,200 Medicaid patients. That's about 55% of the total nursing facility in Hawaii. And we have about 65 in ID facilities for a total of 2,300. And on the community side, we have about 2,600 in fosters, about 2,800 in a DDD program, and about 2,000 that are placed in community under the managed care plans, and about 75 in an E-ARCH. So Medicaid has very few patients in the ALFs, assisted living facility, or the ARCHs, E-ARCHs. Most of our patients sit in these programs on this slide. Next slide, please. So nursing facility, the statewide bed capacity is about 4,500. Medicaid takes about 2,200, which if, assuming the bed capacity is 90% filled, we take about 55%. DDD is 100% Medicaid because it's a Medicaid waiver program. And fosters is about 90% Medicaid. And then the home and community services run by the managed care plans is 100% Medicaid. Next slide, please. So this is a really interesting slide, and this slide took us years of work to get to. So it's deceiving, but this represents many Excel sheets of data. So what this represents is Medicaid has a MOA with the Department of Health Vital Statistics, and we pull all the death records by month, by year, and we map it to the Medicaid patients and what program they're in. And in January and February, our nursing facility deaths were actually up 18%, which is kind of interesting. I don't know why. But in March and April, our nursing facility deaths were down 14%. And in May, it was down 48%. So dramatic reduction in deaths in the past 3 months. And we think it's, we attribute it to all the good work of all the long-term care facilities, HAH, Al Yazawa's team, and infection control measures. But what's really interesting with that number is we have very few COVID deaths. So most of those deaths are from other infectious diseases like flu or, other things. So that was really interesting to me. The other thing is, if you go on to the third line, the foster program, in January and February, we were even. In March, our deaths were down 40%, and May is down 37%, which is really interesting. And if you go on to the DDD waiver was very difficult because that program has very few deaths, a lot of young patients in that program. So we have single digits of deaths. So just a few numbers really skews the data in DDD. But in January, February, it was up 100%. In March and April, it's down 25 to 50%. And in May, it's down 75%. So again, small numbers, but following the same trends, which is interesting. Now, in our CCS program, which is the SMI program, we saw the opposite. So what's interesting, with our SMI program, we're actually up in deaths in March and April. So that was kind of interesting to me. So that tells me that their deaths are not necessarily due to infection control measures, but other access to care kind of measures. Next slide, please. And these are the actual numbers of deaths. So if you look at nursing facility, in 2019, we averaged 65 deaths per month. And January, we had 75, February, 78, March, 56, April, 56, and in May, 34. And then you can see the other programs follow similar trends, except the CCS program on the bottom with the SMI population. Next slide, please. So this is one of my favorite slides. It's the 4 different waves of COVID. So if you look at the purple slide, the first wave, that's the wave that like New York City had a lot of early deaths. So at the same time, you have these other waves starting, second wave, third wave, and fourth wave. And if we had more time, we'd go through each of these waves. But what's really interesting to me is that we haven't had the first wave in Hawaii yet. All these other waves start up. So you have all this kind of collateral damage from COVID waiting for that first wave to come. So in some sense, it's good that Hawaii has very, very low mortality rates, but in another sense, it's bad because we have a long ways to go before we have a lot of people immune to COVID. So we got to keep track of this second, third, and fourth wave of collateral damage. Next slide, please. So speaking of kind of other causes of death, the influenza. So in influenza, the CDC puts out an estimate in terms of deaths, and they estimate that in Hawaii there's 100 to 150 influenza deaths per year. So to contrast that, we've had 17 deaths from COVID this year. So that kind of makes me think that the influenza immunizations is going to be critical going forward, because if we had less influenza this year, we have less people immune going into next year. Next slide, please. And then this slide, the green line is influenza in Hawaii. So you can see in the last couple months, it's below the baseline. The blue line is the baseline flu that we normally have in Hawaii. So that's good. But again, going forward, we have less people immune because less people got influenza. Next slide, please. So another interesting category is dialysis patients. So when you think of Medicaid patients, Medicaid is a risk factor. Poverty is a risk factor for COVID, but dialysis is a CDC risk factor. And if you have dialysis and long-term care, then you have kind of this trifecta of risk factors. So dialysis is going to be a huge issue going forward because dialysis patients, you can't put off their appointments. You can't do televideo. They have to go out 3 times a week. They have many, many touches. So they're high risk to get COVID. They're high risk to get sicker if they get COVID. And they're going to be complicated in terms of transportation and we want to prevent them from getting other people COVID. So dialysis patients we want to track going forward. Next slide, please. So I pulled all the dialysis patients in Medicaid, and we had about 400 that were both dialysis and long-term care. And 45 were in nursing facilities. 300 were in community-based settings, non-foster. 43 were in foster, and 5 were in a DDD program. So what I can do going forward is we can pull these lists and then send them to the program with the names of the patients and the islands by geography, and then we can have the case managers kind of track these patients closer. Next slide, please. And then one of the things I was thinking of is for fosters in particular. In fosters, one of the strengths of foster program is they become kind of like the new family for the patient. They take them in, they do holidays together, sometimes they plan the funerals, they really become the family. But the downside to that is whenever fosters bring the patients to the doctor, the fosters don't have authority over the patient, so they can't really participate in advanced directives, post-planning. So it's kind of this good and bad with the fosters. Yes, they become family, but they don't have legal authority. So I'm thinking that maybe we should start a task force or group to kind of work with this problem going forward, especially with the COVID crisis, like maybe with UH Geriatrics, our team at HIEMA and Medicaid office, to kind of see what we can do better in this area. Next slide, please. And then in terms of resources, MedQuest has this website. On this website, we have some good handouts that were kind of standardized, and we actually stole from the DDD division. They're really simplified, high yield, good for English second language caregivers, and really helpful, I think, with case managers reaching out to families. So if you get a chance, you can check out the website, try drill down to resources, and then look for these handouts. And in terms of PPE, we're starting to get some PPE that we're aggregating at the state Medicaid office and getting out to the foster programs. We haven't gotten a lot of PPE out to the non-foster programs. And I think DDD is getting the PPE through the Eddie Mercero's BHH surge group. So we're getting some PPE out. One area that we're going to ask the case managers to help us with is if there are caregivers in a home that also work in the nursing facility, and there's a lot we found out, like nurses' aides, then those homes will need surgical masks. So we're going to have to kind of find out which of these homes have staff that are working both in facility and working at home with the patients. So that's the area we need help going forward. Next slide, please. And sorry I raced through the slides, but I want to kind of race through to kind of give some chance for questions at the end. But on the plus side, what I've really found that in this COVID crisis, there's more collaborations and reaching across than I've ever seen. So for that, I'm really grateful. And I'm going to turn it over to Brian Wu now. Brian, are you on the line?
Oh, hi, Curtis. I'm here.
Okay. You can go ahead, buddy.
Yeah, thanks, Curtis. And also, I feel so appreciative of hearing your story firsthand, Dr. Pascual, and at least virtually firsthand. And thank you for reinforcing the power of the mind and reminding us that ears are always open, even when we're not aware of it. I'm Brian Wu. I'm a peds pulmonologist. I'm also HMSC's Medicaid medical director, so work with the vulnerable population. Next slide. So just wanted to kind of go over some respiratory considerations for our nursing facilities and care homes and even self-direct folks. So a lot of this information is from the CDC. So one question is, what's considered an aerosol generating procedure in a healthcare setting? So these are kinds of procedures that are felt to disperse more infectious droplets than someone just coughing, sneezing, talking, or breathing. I think if you click, it'll advance more throughout this slide. Wait, oh, perfect, thank you. So commonly performed procedures that are often considered aerosolized generating, and there isn't always great science behind this. So a lot of it is based on models and best guesses. So open suctioning of airways is considered aerosol generating, and what that is if someone's on a ventilator, if they don't have an inline suction, you open it, then suction them, that they're gonna exhale air through the circuit. The ventilator is going to push out their droplets, so it could be aerosol generating. Other common things could be things like non-invasive ventilation, CPAP, BiPAP, and we'll discuss a little bit more in this talk some considerations for that. And if you could do next slide, I guess, or click it. Thank you. Some procedures that are uncertain if they're aerosol generating, but potentially could be, are nebulizers, high flow oxygen delivery, tracheostomy patients, particularly if they're getting high flow, but even without, and when they're doing NG tube placements, because they're gagging so much, it's an even more forceful cough that could disperse droplets in the air. Next slide. So, one question is, well, if things are getting dispersed in the air for COVID, how long is it going to stay in the air? So there's a letter to the editor in the New England Journal that kind of looked at this. So they actually did a model where they nebulized out SARS and also COVID-19 viruses. So in air, it can be aerosolized. These viruses can be in the air for greater than 3 hours. They stop measuring after 3 hours, and probably after 3 hours or so, it'll, they'll all settle down. But, at least 3 hours, it'll be in the air. On cardboard, 24 to 48 hours. Stainless steel, 72 to 96. Plastic, 72 to 96 hours. So this virus potentially could be, viable on surfaces for some time. That reiterates, our PPE usage and our disinfection. Next slide. So if it's in the air, can someone actually inhale it and become infected by it? It's thought to be the case, but it's not completely clear yet. The CDC states that over long distances, it's unlikely, and it's uncertain if airborne transmission is possible from person to person. And because it's uncertain, we should take those precautions. And primary way of transmission of COVID is respiratory droplets, but potentially could be occurred with contaminated surfaces. So you touch something and then you inoculate yourself by rubbing your eye or rubbing your nose. So even when you wear the masks, being very, very aware, because we often touch our faces unaware of doing so, of touching your face, readjusting your mask, rubbing your nose under your mask. Next slide. Thank you. How long of a distance before it's not a risk anymore? That's unclear. We know that at 3 feet, it is much higher risk for getting infectious droplets than less than 3 feet. 6 feet is what a lot of people hear, minimum 3 feet. But up to 10 feet or more, you could still potentially have this. There's actually a yet to be published paper coming out from China where they kind of cultured out, swabbed their areas where they had COVID-19 patients, and up to 14 feet where they could still culture it out. So again, just being aware of our surroundings and infection control. Next slide. So what PPE should be worn by healthcare personnel providing care to patients not suspected to have COVID-19, and whoever's on this call, I know you have had multiple talks regarding this. This is just kind of CDC guidance I pulled off, kind of concentrating on respiratory droplets. So please interrupt me if I'm saying something different from what's been educated before. But, patients should wear masks if possible in a healthcare facility. If they're in a CCFFH or others, you do the best you can. You try to decrease the risks as much as possible with what resources you have, is kind of the general guidance. Healthcare personnel should wear surgical masks instead of cloth face masks in healthcare facilities. Again, for the smaller homes, a little bit vaguer guidelines regarding that. But I know Curtis does have some guidelines from the DOH for that. Next slide. The CDC guidance is if there's a community that has moderate to substantial transmission of COVID, they should go, really much more cautious with wearing N95 or higher level respirators if they're doing any aerosol generating procedures, face masks, eye protections. Next slide. If they're in an area with minimal to no community transmission, according to CDC, they said that N95s for aerosol generating procedures are optional and eye protection is optional. Next slide. Well, you should wear face masks. So where are we? I'm awaiting DOH to kind of see if they can provide clear guidelines for where are we locally. This is CDC on the left, where they talk about what is substantial uncontrolled community transmission and what is minimal to moderate community transmission. And then that our state, we also have our impact, color levels with stay at home, safer at home, or whatnot. So do these impact levels, do we have a clear correlation with community transmission level and our impact level? I'm awaiting guidelines from DOH for that, because our impact level isn't only based on disease spread in our community, it's based on other factors as well. So sometimes it's hard to make that direct correlation. Next slide. So what if we don't have proper PPE? Well, if you're a healthcare facility and you're taking care of someone with COVID-19 who needs like nebulizer therapy, well, according to the American Healthcare Association, and I forget what NCAL, I think it's a nursing facility association, I believe. They said, well, you shouldn't take care of them. Well, what if you're in not a large, SNF? What if you're in a small home? That's a little vaguer guidelines for that. But if you have N95, again, it's reducing your risk as much as possible with what resources you have. It really should be that consideration, especially if you have multiple high-risk people in that home. And reserve your N95 for appropriate usage. Oh, thank you, Patrick, for the NCAL definition. Next slide. So nebulized medications, according to CDC, a question is, well, if you have someone with asthma, should you change their treatment plan because of COVID-19? This is the closest I could find for CD guidelines on nebulized medications. So I kind of expanded that. So basically, if you have someone getting nebulized medications and you're in a home setting, so you're not with a lot of other high-risk, patients or people, well, you want to really use a location that minimizes exposure. Because again, nebulizers is unclear if it's an aerosol generating procedure. It's possible, we don't know yet. And if you're in a home setting, go to an area where the air is not recirculating in their home, like outside or patio or garage where it's completely separate. Next slide. Face mask nebulized administration is probably higher risk than a mouthpiece, because when they have a face mask on, they're exhaling, so you have this jet stream from the nebulizer and they're exhaling, so it's going to shoot out of those little vent holes to the mask. So mouthpiece would be much more ideal than a face mask if possible. And then HEPA filters, which is probably not logistically possible with nebulizers for the most part. Next slide. So how do you avoid unnecessary neb use? Well, control their underlying conditions with appropriate controller medications. If they're a smoker, even more so, this might be an opportune time where people may be more eager to stop smoking if you tell them about COVID and lung disease. And if they have nebulizers, converting them to inhalers would be ideal, but make sure that you're administering it or educating how to administer it correctly. YouTube's great for visual instruction on how to use inhalers with spacers, aka valve holding chambers, appropriately. Next slide. So what if you have to administer aerosol generating procedure in someone with COVID? Again, we kind of already talked about this, but if possible, limit a room or limit to the room only essential people that need to be there during the aerosol generating procedure. Use proper PPE. I know our facilities don't have negative pressure rooms, but it's really isolating as much as possible. And I know on a lot of these echo talks, these discussions have been had. And again, reinforcing the cleaning properly for it. Next slide. So PAP devices, so that's, CPAP, BiPAP, or if you have someone on non-invasive positive pressure, so like a trilogy with a nasal cannula or a mask on it. So, according to guidelines, if they have COVID or suspected to have COVID, you should use, full PPE and possibly be in a negative pressure room. Next slide. According to the American Thoracic Society, for CPAP, BiPAP usage for home, this is for home setting, if basically they say, if possible, if you think they might be sick with COVID and they could tolerate, let's say they had obstructive sleep apnea, but they're not horribly going to become hypoxemic from obstructive sleep apnea. Well, try not to use PAP until 3 days after they're completely asymptomatic. But if they have to use CPAP, again, try to have them in their own isolated room with their own separate bathroom if possible. Again, similar measures that you would use with anyone that you might think has COVID. And there are, disinfect with appropriate material, not only the room, but the equipment itself. Use manufacturer recommendations. Next slide. Oh, and to also clean the CPAP, BiPAP equipment daily instead of the typical weekly. And then this came out, again, this is a letter to the editor in a sleep journal where these providers actually connected a bacterial viral filter to a full face mask, a non-vented full face mask. Is this a recommendation to all of you? No, this is a complete outside the box thinking of what possibly could be a consideration if you have no other kind of options occurring. Because we want to try to maintain our hospital facilities if possible, but in case we don't have facilities available, talk to providers. If you're at a SNF, talk to the respiratory therapist. And if anyone ever has questions, they can always contact me, and I can try my best to try and answer those as well. But next slide. I think that's my last slide. That's it. Thank you so much.
Wow, that's great, Dr. Wu. Good to have a pulmonologist perspective. We're going to move on to Dr. Ryan Lee with the DDD division. Go ahead, Dr. Lee.
Thank you, Curtis, and thank you, Dr. P, for sharing your experience, real inspiring, and Brian for such a comprehensive presentation on pulmonary aspects of COVID. And to Curtis for inviting us to share a little bit about the DDD and who we are, what we do, but also his strong presence in supporting us. His collaboration, both clinically and administratively, have really improved our division as a whole. So we thank Curtis for his constant support of us. I work at the DDD as the medical director. I'm a pediatric neurologist by training with specialty in neurodevelopmental disabilities. And we serve as a branch under the Department of Health and the Behavioral Health Administration. Next slide. Apologize for some of the formatting, but we exist to support people with intellectual and developmental disabilities. We want them to live meaningful, safe, healthy lives that are self-determined. We truly work towards quality care for them, family-focused services, and then we really do want them to live self-determined lives that allow them not just choice, but working with the circle of support around them to allow them to live the most fulfilling lives that they can live. Slide. Next. Next. So we service, and maybe you can slide through all of these numbers here so I can just show the array, but thank you, John. So we service the lifespan of individuals with intellectual and developmental disabilities. And I think there's one or two more numbers there to show, but we may find them eligible in early childhood and then tend to continue to support them because the people with disorders that we serve maintain them through their lifespan. The eligibility criteria largely consists of how substantially impacted they are in their life activities. And so, as you can see, we service primarily adults, meaning the age 56 and older, I think, is about 800 or 600 or so. And those that are 23 to 55, close to 2,000. We also do service school age and early childhood, but the services tend to look different in the early ages due to the other statewide supports that are available to children. Slide. And that's a bit of an old number, but there was about 3,400 or so in 2019. That's just to give you a snapshot of the number of people that we service statewide. Next slide. We have 15 units statewide that service individuals with developmental disabilities. Those are 3 units on the Big Island. We have a unit on Maui, Molokai, Lanai, Kauai, and several units on Oahu. The rest of the units are on Oahu, actually, 1 through 10. And each unit has a building that consists of intake workers that gather documents for eligibility. And then there are case managers and case management supervisors, and then a unit nurse on every unit on Oahu at least. But the neighbor islands do not have a unit nurse, and so Oahu nurses support the neighbor islands for nursing needs. Next. This is just a brief overview of our eligibility, meaning who is allowed to receive services in our program. And we can break it down into 2 broad categories of diagnostic eligibility, and that's individuals with intellectual disability and then those with developmental disability. So intellectual disability, as you all know, is a DSM-5 diagnosis consisting of intelligence quotient or cognitive testing that falls at least 2 standard deviations below the mean. So general standard scores of 70 or under, and that also have at least one substantial area of functional limitation that is due to the general cognitive impairment. And then there's an age criteria of it being present, the symptoms being present before the age of 18. On the other hand, applicants can also have one of the several developmental disabilities that are federally defined within our population, and those include cerebral palsy, autism spectrum disorder, epilepsy, and according to our statutes, there is a 4th kind of a wastebasket or general category of neurological conditions, but they have to have cognitive impairment and adaptive impairments that are equivalent to an intellectual disability. And these, the age has to be present, the symptoms have to be present before the age of 22, likely to receive lifelong services and receive continued care. And then again, they have to have functional impairments. Next slide. The second part of the criteria, besides having an eligible diagnosis, is having standardized testing scores. Generally, these 2 tests that we use are the Vineland Adaptive Behavioral Scales, or the ABAS, which is an adaptive behavior assessment. And they need to have substantial deficits on those test scores in at least 3 of these major life activity. And that word substantial is defined in our statutes by at least 3 standard deviations. So there's a higher calling or a higher criteria for severity in these substantial deficits, with standard score generally falling below 55 or 3 or more standard deviations below the norm in order to qualify for eligibility. Next slide. The DDD services that we provide, case management services, as I mentioned, case managers are working within our division, and there's about 6 per unit statewide, and we have 15 units. And they provide assessment, planning, monitoring for individualized and specialized planning for individuals needing supports. The adult residential services and adult foster homes, there are some state-funded services that people who don't qualify for the waiver might get support from. And then there's the majority of our population that we support are in the home and community-based services Medicaid waiver program. Within that, there's an array of support services that we provide that support habilitation goals. These might include personal habilitation assistants, PAB workers. We have behavioral supports that we provide, such as training and consultation for initial training for people with, say, autism who need ABA services, and ongoing support. Although we do not provide ABA services as a service directly from our DDD program. We have CLS, which is community learning services, both individual and group. And then we provide partnering with agencies throughout the state to provide adult day health support and respite also, and then some employment services and training. Next slide. And then I'll talk briefly about a tool that we have just developed, newly developed in the last couple of weeks here, and are about to roll it out through a training for our providers of care throughout the state here. And that is a self-assessment tool as they seek to open up. So they're looking to open up day services, that's ADH programs throughout the state. And we don't have a date yet when they can open, but we wanted to systematically implement guidances for them so that we can have a coordinated effort in maintaining a standard of care throughout the state, as our participants may or may not want to go back to these programs that they had been involved with pre-COVID. And so next slide. Some of the main categories that we are going to touch on are the core elements of having an emergency preparedness plan, focus on transportation needs for those that require transportation through the ADH programs, preventing the spread of infection through screening, social distancing, and infection control, how to create a person-centered plan where we focus on the wants and needs of the individual that is being serviced, whether or not they even want to go back or not, or whether or not they want it to change in services that they're receiving. And then training and support for the agency and their employees. And then looking at those community-based services, such as the individual services and group services, and how to support them in assessing whether or not we can provide a safe and healthy environment that assures participants in our program and their families that they're going back into something that will keep them safe. Next slide. So this is just a snapshot of one of the introduction areas of our 17-page assessment tool that is for providers of these provider agencies of services for our participants, and it looks at each item which we have gathered from federal, state, and local guidances and summarized for them some of the key points that they need to include within each area. And this is just an example of emergency preparedness and how they would click on a box whether or not they've completed it, it's in progress or not started. And then they would discuss with us strategies and what documents and policies, procedures they have, and then have notes. And we have sections like this that cover all of the core elements, and it allows them a framework by which to think about how to create a safe program as they seek to reopen. Next. And that's it for my section. I'll turn it back to Curtis.
Yeah, thanks, Dr. Lee. That was great. So DDD, ballpark 3,000 patients. DDD covers long-term care. So that was the reason why we had Ryan present today. They cover that home and community-based services. So a really high-risk population, similar to the elderly, I think. And then I really liked both presentations, great. And Ida, we wanted to go back to you and see if there were questions.
Yeah, I know that you guys have been working really hard on talking about how to provide education and resources to the community care family foster homes. Can you speak to that a little bit of how case managers can help with that?
Yeah, so that's still work in progress with us. The one thing we did do is we settled on a set handouts as a standard across DDD and MidQuest, and similar handouts that we gave to Al Yazawa. But what we haven't done yet is we're trying to take a crack at getting a checklist, like what is the bare minimum that the case manager should be going over with each home. And we've collected some ideas from different case managers, but we haven't come up with a draft of that yet. So that's kind of next on our to-do list.
Okay, great. Okay, and if I heard correctly, I heard somebody say, like, right, adult day health guidance. Is that because I realize that there are actually providers out there who are open already, right? Have you been in touch with them?
Not on the DDD side, but DDD is considering reopening. But DDD has adult day health similar to the geriatric adult day health.
Okay. So it might be good to have those similar conversations for both. Great. Any other questions from the audience? Want to just open that up?
Yes, hi, this is Dan Saltman. Thank you, Curtis, and everybody, and Dr. Pasqua for sharing your insights into what's going on here. Curtis, I was wondering if that Medicaid mortality data was sort of puzzling. I'm wondering if you think if the Medicaid mortality is representative of the overall mortality, or if you have any other information regarding what they call the excess deaths in the state that sometimes is about unmeasured COVID mortality.
Yeah, good question, Dr. Saltman. I don't know, Medicaid covers about 25% of the state, so it's only one section of the state. But, in certain populations like geriatric long-term care, we're a bigger percentage, I think. So I think it's trending data really, and it's early data, and it's imperfect data. But I think the trends are still important as opposed to the exact numbers.
I'll be curious to see how it unfolds over the next few months. Okay. Great. All right.
Ida, this is Nicole Poliona. We had a little email exchange yesterday about COVID testing prior to placement in geriatric foster families and care homes. Mm-hmm. Would this be an appropriate place to talk about that?
Maybe. We do have like 1 minute left, but I guess just wanted to get the sense of right now, are the family foster homes getting patients discharged from the hospital with COVID testing? Right now, as it stands, it's one test if they're COVID negative or not PUI, and 2 tests if they are either have been COVID positive in the past during their hospital stay. And I guess that was the concern amongst our medical directors of nursing facilities, that maybe this wasn't conservative enough, and just wondering about how the this the community care and foster families feel about the testing criteria for transferring back to the community setting.
Yeah, so it's a question we'll bring up with Department of Health, the Sarah Kemp, Sarah Park's office, because on one, in one camp, they're kind of going home to the home setting, but in another sense, they're ICF-SNF patients going to a kind of semi-aggregate setting. So I'm in a camp that we should, as much as we can, try to treat them similar to the facility patients in terms of testing. But I know Al has a group meeting on Friday, and we can bring up that question to them.
Yeah, I think this is it's a work in progress, while there are actually no guidance regarding, there's minimum guidance from DOH and CDC regarding what test is required, and so it's kind of up to us, I think, regarding how conservative do we want to be, and that's the discussion right now. So yeah, so if folks who care for patients in these settings want to send us an email, send us your concerns, we are, be talking to folks to try to see if we can come up with some consensus of what's recommended to protect our vulnerable patients, because they are very vulnerable, and the settings that they're in are very hard structurally to quarantine and to isolate. They it's inherently impossible almost. So that's why we are extra cautious. Okay, well, we are at the top of the hour. Just want to let you know, in order to don't forget to get your CMEs, find the online evaluation form and complete the CME and provide any input or suggestions of what other talks you want to hear in the future. And thanks very much for coming. And hopefully next week you'll join us, and we'll be talking about supporting our home care heroes, our home care agencies and our home care providers, hospices, and things like that, with experience from the Visiting Nurse Services of New York, who will be joining us. So thank you very much, everybody, and we'll see you next week.